Okay, welcome everyone to the September 4th Addiction Toxicology Case Conference. This is jointly sponsored by the American College of Medical Toxicology, the American Society of Addiction Medicine, and the Opioid Response Network. And funding for this initiative was made possible in part by a grant from SAMHSA. The views expressed in written conference materials and in speakers or moderators' presentations do not necessarily reflect the official policies of the Department of Health or the U.S. government. This is designated for CE accreditation if you complete the afterward questionnaire or complete the questionnaire available through the ASAM website. I want to introduce myself. I'm Tim Wiegand, the Director of Toxicology at the University of Rochester Medical Center, medical toxicologist and addictionologist. Joining me is Dr. Gloria Bashevitz, the Medical Director of Strong Recovery and Professor of Clinical Psychiatry in the Department of Psychiatry at the University of Rochester Medical Center in Rochester, New York. We have distinguished panelists. Dr. Michael Hodgman is the Medical Director of the SUNY Upstate Poison Center in Syracuse, New York, and Assistant Professor of Emergency Medicine at the Upstate Medical Center in Syracuse, New York. Dr. John Hopper is a clinical professor at Wayne State University School of Medicine in Detroit, Michigan. He's an ASAM expert joining us today. And Dr. Joanne Lace is a medical toxicologist, an addiction-trained physician, an attending physician in the Division of Addiction Medicine at Hennepin County Medical Center in Minneapolis, Minnesota. And Dr. Barry Logan is a guest expert. He's the Executive Director for the Center of Forensic Science and Research and Education at the Frederick Readers Family Renaissance Foundation. He's also the Senior Vice President of Forensic Sciences and Chief Scientist of NMS Labs in Willow Grove, Pennsylvania. And I want to thank our panelists for joining. None of our speakers have any conflicts of interest to disclose, and we'll jump right into the first case. I want to remind the audience that you can chat in questions or comments, and we will be reviewing these and should have some time at the end of the three cases to also have some general discussion. The first case is titled Preliminary Positive but Confirmed Negative. And we start with a 34-year-old gentleman who has a history of opioid and sedative use disorder, who has been doing well with his opioid use, taking buprenorphine appropriately, and not using any other opioids, yet his parents have been concerned about other substance use. He's been enrolled in an outpatient treatment program since 2019, where he has monthly visits with an addiction-trained physician for counseling and medications for opioid use disorder, as well as for mental health. And he also receives additional counseling via CASAC counselor and has an opioid group, which he's intermittently engaged with depending on whether or not he's working or whether really he's struggling with his other substance use. The patient has started using prescription opioids about 7 to 8 years ago after an injury during bodybuilding training, which he subsequently stopped doing, and his use progressed from his own prescription opioid supply to illicitly purchasing prescription opioids to heroin and heroin fentanyl, and he also started using benzodiazepines and cannabis. His use has interfered with his personal and his family life, and he's lost several jobs over it, including one working closely with his father, in which he'd been expected to move into his father's position as his father retired, working for a friend of the family who owned a packing plant, and that caused a lot of family distress. After a few months of compliance issues with buprenorphine, but not other opioid use, he really seemed to start regularly taking the dual formulation, the 8/2 buprenorphine naloxone, and then switched to the subcutaneous buprenorphine injection for 6 months until an insurance change, loss of insurance with job loss, necessitated switching back to the dual product, which was the generic product. His parents paid out of pocket for it briefly, and he did well with the buprenorphine throughout this period. Throughout the end of 2019 and 20, the patient denies regular benzodiazepine use, yet regularly has alprazolam metabolites, clonazepam metabolites return positive on random urine screens. His parents also describe episodes of disinhibition, falls, memory issues, and even finding him slumped over the side of his bed, knees up to his armpits, head down, difficult to rouse. His mom took a picture and sent it to the counselor during one of these episodes and had saved it to share with her son. And seeing this picture was very concerning that the position he was in, he would really have had trouble breathing. And I was very glad to see that he was, not been hospitalized or not had, respiratory arrest, but told the mother that I was very concerned that she needed to call 911 if she finds a son like this and not responding. The patient is provided consent to discuss treatment with progress with his parents and for the counselor and physician to talk, and a team meeting with the patient and mother were arranged via Zoom early in the year. Prior to this meeting call with his counselor, his mother indicated they installed a tracking device in the car and he appeared to make one particular stop at the same address and then always running around the same routes after the stop prior to his episodes of intoxication. And he was doing some delivery service with Uber and some food delivery service, which is why he was, had the driving and was out during the day. Early in 2020, his benzodiazepine screens continued to result, but then the confirmation returned negative, all reported benzodiazepines, and I'll show you what our panel includes in an upcoming slide. His meds include sertraline, valproic acid at 500 twice a day, and this was started as he regularly had the clonazepam and alprazolam as an adjunct to minimum withdrawal symptoms, as I expect, I was trying to get him to stop. He declined entering an inpatient or a detox program to try and first stabilize and then make sure he wasn't going into benzodiazepine withdrawal. We had adjunctive clonidine for anxiety twice a day, and then the buprenorphine naloxone. His mother asked if his patients might be causing some of the episodes, as the patient blamed really his episodes on his medications. And this is prior to the Zoom meeting, and I indicated that they really shouldn't be unless he had been taken inappropriately. And then she also asked that we not disclose the tracking device on the car to the patient during the Zoom meeting. In 2020, the confirmations were negative for all benzodiazepines, including clonazepam and metabolites. For preliminary screens reconstructive, and this is a screenshot of just the series of preliminary positive C result. The C result would be linked to the panel of benzodiazepines, which are showing that they were negative. So for the preliminary, which is an amino acid, is positive, trigger, reflex, confirmatory screen. And he had reported cessation of use despite these persistent episodes that his family describes. And parents and provider were terrified about his driving and told him this, and his parents even wrestled with no longer letting him stay at home if he persisted in using whatever he had been using. The last on-site screen before the pre-COVID-19 changes, which limited in-person access, although the injectables were continued to bring in intermittently for single visits, include a positive benzodiazepine screen, which was confirmed negative, some small amounts of cannabis, which I believe results are around in the low 30s per nanogram per milligram, and the buprenorphine metabolites were also positive. This is the panel of benzodiazepines that are run if the preliminary screen is positive and includes diazepam metabolites, the nordiazepam, oxazepam, and lorazepam, temazepam, alprazolam and metabolites, clonazepam and metabolites, flunitrazepam, triazolam, flurazepam, midazolam, and estazolam. So it's fairly comprehensive for benzodiazepine metabolites, at least regularly available benzodiazepines. As I mentioned, the patient had good buprenorphine metabolite levels. They weren't fluctuating, and this is the last screen pre-COVID, confirmed on the 3rd of March. So my question to the panel is, what is your interpretation of the preliminary positive yet confirmation negative for the benzodiazepine screen? And we'll start with that first, and maybe we'll start with Dr. Bashevitz. Can you comment on first what this means to you and how often maybe do you see this?
Well, we see this with some fair regularity, and of course, one of the initial thoughts would be, is the person having a false positive from some other medicine they're taking, like a non-benzo medicine, or perhaps they're taking some benzo that is not assayed in the screen, maybe some sort of designer benzo or something they got over the internet that's not available in the U.S., that sort of thing.
Thank you. Dr. Lace, do you have anything to add to the comments Dr. Bashevitz had?
I agree. It's really important to talk to the lab about what the false positives are. historically there was sertraline and oxyprazicin listed and other NSAIDs. However, the assays were reported to have improved since then. So given the technology that we're using now, I would be suspect that there would be something that may not be, a type of benzodiazepine that may not be screened for in this.
We had from one of the panelists, Dr. Ingrid Vikas, had mentioned that there have been reports of false positive benzodiazepine screens with sertraline. Dr. Hopper, do you have any comments on this? Do you see this in your clinical practice?
No, yeah, I would agree that sertraline, certainly in immunoassays, have seen false positives, but in this case, as the other panelists have said, I'd think about designer benzos, which we are seeing a lot of in the COVID era.
Dr. Logan, and your position is forensic toxicologist in the lab. Can you comment a little bit on maybe the process and difference between preliminary, confirmatory screens, and what this would mean to you from your perspective as well?
So we're seeing also in our casework, both our death investigation casework as well as our human performance cases, so for predominantly drug-impaired driving cases, increasing rates of unconfirmed benzodiazepine positive screens. So the screens, as has been discussed, are typically run by an immunoassay procedure, either ELISA or enzyme immunoassay. And the antibodies have varying degrees of cross-reactivity, particularly to some of the new emergent designer benzos. Some of them actually have a lot higher rates of cross-reactivity on the immunoassays, which can be another complicating factor. Sometimes the immunoassay is so sensitive, and even if the drug is in the confirmatory panel, it may not be sensitive enough to pick up the amount of drug that caused the positive on the screen. So increasing, as a couple of the panelists have mentioned, increasing rates of this, particularly in the last few months. We've had our highest rates of designer benzodiazepines just in the last 2 or 3 months.
All right, thank you. We'll get into more details on some of the specific benzodiazepines, but I want to ask some of the panelists what treatments are available for sedative and benzodiazepine use disorder. This particular individual really would struggle indicating that he had an actual sedative use disorder, and that despite even having the confirmatory screens early on for alprazolam and clonazepam, indicating that he had used them had been a challenge. And so self-report and guilt and shame were things that were really, but I'm wondering what other medications for craving or simply detox, what would you do for this patient, or any patient with sedative use disorder? Dr. Bishevitz.
Well, I think the first step would be getting the patient to admit to the benzodiazepine use disorder, and that can be very tricky and can take a very long time. In fact, sometimes we work months with people like this who gradually come to understand that they're having a problem. So I would focus on that at first. There is no FDA-approved medication for cravings for benzos, and usually people fit into traditional outpatient chemical dependency treatments of various sorts or inpatient.
Right. I've had a couple of recent patients that I've struggled with that have had a sedative use disorder and on referral to mental health, had convinced the mental health provider without really good communication to re-prescribe benzodiazepines and then come back with a, look, see, I do need them. And it's really been a challenge. So really coordinating communication is critical because, I see still a lot of prescription of benzodiazepines to patients with opioid use disorder. And occasionally they are indicated, but in my experience, many of them are really not and contributing to the problem and greatly increase the risk of overdose. Dr. Lace, do you have any on this, or what is your experience with benzodiazepine use disorder?
It's really difficult. I don't do a ton of longitudinal outpatient work. I try to do a brief taper using a barbiturate or a long-acting benzodiazepine while they're inpatient, but I'm just not sure what happens when they leave. I'm assuming many of them resume the benzodiazepine use.
I think that happens. Following longitudinal buprenorphine, and the detox is not that challenging. And in my experience, tapers outpatient with benzodiazepines are almost impossible. Can't recall ever seeing a taper with someone that struggled with benzodiazepine use disorder actually work in an outpatient setting. So we use phenobarbital over 3 days inpatient. But then for craving and getting used to working with anxiety really takes detailed cognitive behavioral therapy and a lot of work with the patients, the appropriate anti-anxiety medications, serotonin reuptake inhibitors, or buspirone. And I like to use sometimes adjunctive clonidine, and the valproic acid was taken from the ambulatory detox literature that kind of raising the GABA levels seemed to help with just kind of some protractors. So I like to use that for a couple of weeks. But does anybody have any comments? Hopper, do you have anything you'd like to add?
I use a similar approach as has been mentioned already. Typically for patients on long-term benzos, I will use phenobarbital as my tapering agent. I've tried long-acting benzos, but it sometimes is a little confusing for the patient. Why are you giving me the drug that I was taking? They tend not to like the phenobarb as much, but it tends to do well. And then I do use valproic acid as sort of a transitional drug, but agree that a very large proportion of patients who have been on long-term benzos are ultimately going to go back on them, hopefully at a lower dose and more controlled, long-acting fashion. So I will consider it a victory for that patient on alprazolam that they've been taking from friends or off the street. And if we get them on a stable, long drug like clonazepam, then that's sort of a harm reduction approach.
Dr. Hodgman, can you comment on the poison center experience, or even your clinical experience with designer benzodiazepines? Are you aware if the poison centers noticed any uptick in reports with designer benzodiazepines?
I think we're limited by we don't do a lot of testing for these. As far as the phone calls we get in, we only probably do that through our own institution here. And so it's kind of difficult to say how much of a pattern of those we're seeing, although, if it's similar to here at Upstate, we have seen some cases, probably atizolam being the more common one. But the other thing I wanted to comment on was, as far as acute benzo withdrawal and treatment, I don't have that longitudinal experience like Joanne. It's usually just the acute phase. But I became interested in, and this I'd give this to the other panelists as a question. I was unaware of, I kind of learned from you this microdosing of buprenorphine, and I found that fascinating. And looking back, there's a little bit of literature on doing something similar with flumazenil for benzodiazepine withdrawal. And I don't know if anyone on the panel here has any experience with this. I've read a little bit about it. It sounds like something that might be promising, although it certainly needs more study.
That's an interesting point. I think, I've seen papers referring to use of flumazenil, which actually is a low-level partial agonist, so not really unlike buprenorphine, but has a lot lower activity from what I understand. So I have seen that, and I've not done that at all, but I am aware of literature regarding that. I tend to use the phenobarbital and then have the slow auto taper, and I don't know how that would compare with the flumazenil use, but I've seen reference to that as well. Does any other panelists have any points on that?
This is John Hopper. I don't have experience with flumazenil, but I did want to mention that atizolam was noted by Dr. Hodgman, and there have been a number of reports of street benzos that are mostly atizolam. And if you look at the Airwood website where they do drug testing, they've had a number of pills that have been sent in that are containing atizolam. So that does seem to be relatively prevalent right now.
Right. Yeah, thank you. And Mike's in our area where the chemistry, where the state crime lab has had some data on sample confiscated tablets, atizolam was common, although we have a different benzodiazepine that's replaced atizolam, it seems, and we'll get into what that is. There's been some great comments in the chat. Dr. Logan had mentioned that because of the many counterfeit pills in circulation, most patients don't know what was actually in the pills they took. Relying on recollection may take you in the wrong direction as far as treatment is concerned. And there's been mention of use of gabapentin or clonidine in addition to SSRI medication and hydroxyzine and sometimes Seroquel or quetiapine used for sedative use disorder. And we'll comment a little bit about that at the end, as I'm hesitant to add some other often opioid potentiators, especially if the patient has opioid use disorder acutely, but maybe not chronically. So let's continue with the case because we want to stay on track. After the patient was confronted with the photographs showing him unresponsive, his mother was given a Narcan kit. And I had advised that she call 911 if she finds him unresponsive again or in a similar state of intoxication, and to give him a dose of naloxone. I thought that was very concerned, first of all, making sure that he was actually breathing, but I thought that that may be really useful as a rather dramatic demonstration to him as well as saving his life. A patient subsequently does admit that he's been getting some pressed Xanax from a guy he no longer has access to, and he says that he is aware that it's not really Xanax or a Prazolam, but something the guy had been ordering over the internet and pressing into bars. And he mentions he's aware that there's quite a bit of this going around, and it feels, and this is a quote, not quite like the Prazolam, but close, not as euphoric, but stronger, if that makes sense. And so my question is, what type of substances have been found in the counterfeit Prazolam Xanax bars? And we've already had a little bit of this comment. Dr. Hodgman mentioned atizolam, which in my experience, it was very common. There's reports of atizolam being pressed into the Prazolam bars with fentanyl on occasion. There's reports out of California with some fentanyl adulteration. And we've had counterfeit Prazolam bars. Most recently, people are referring them to as the green hulks. And just a few days ago, I had a patient's wife showing me a pill that she knew the patient was using and was a pressed alprazolam bar. The green hulks because they're green in color and look like one of the regularly manufactured alprazolam bars. And so I don't want to get too much into what other substances have been found because that's kind of similar to the next question. What is the state of the designer benzodiazepine market in the U.S. and availability? And Dr. Logan, maybe you can comment on what you're seeing most recently with the forensic data that you're collecting and compare driving results.
Sure. So interestingly, we probably see fentanyl more often in counterfeit Xanax bars than we see benzodiazepines. And in the past, we've seen carfentanil when the fentanyl analogs were popular. But with the rise recently in designer benzodiazepines, that is becoming one of the most common vehicles is the counterfeit Xanax bars for the designer benzos. So we started seeing these back with some level of positivity back in about 2016. It seemed at the time that they were more cyclonauts for people who were connoisseurs looking for a different kind of high that were ordering things on the internet for their own purposes. But and then so we were seeing atizolam, we were seeing clonazepam, flubromazolam was one of the early ones back in 2016, but not a big percentage of our positive benzodiazepine cases. Things really started to take off principally for atizolam, and it has been increasing through the end of last year as the most prominent counterfeit or designer benzodiazepine, again, most often in Xanax bars. The flubromazolam I mentioned was one of the earliest appearing ones. It also saw a resurgence of positivity back in the end of 2019. But really, the dominant compound now, starting late last fall and into the present time, is flualprazolam. So that's a fluorinated version of alprazolam. Fluorination of these compounds tend to add potency. There isn't any good laboratory-based studies on what the relative potency of flualprazolam to alprazolam is, but just based on the chemistry and structure-activity relationships, it's likely to be at least as or more potent than alprazolam. So that's really what the market looks like now. There's probably a half dozen or so drugs that are commonly encountered, but flualprazolam is number one.
And I want to comment from my experience in speaking with individuals and spending time looking at, the relative doses and potencies from where there is data available. Some of these synthetic and designer benzodiazepines are actually available in other countries, if I'm not mistaken. Isn't tetizolam available in some of the Scandinavian countries, Norway, Finland, and I think Russia, along with some of the others, and some are just purely synthetic and analogs of other benzodiazepines.
Yes.
I had ordering benzodiazepines with such potency that they were pressed onto blotter paper, so sub-milligram doses, 100 micrograms to 500 micrograms, and others that were of similar potencies of diazepam. Tetizolam seemed to have similar potencies as alprazolam from my review of literature, but I know that there is a wide variability, and that's not simply all that is involved with the clinical effects when at benzodiazepine use. Does that coincide with your experience?
Yes. Yeah. We haven't really looked at there isn't really any information that I know about regarding the quantity of the drug or the doses of drug that is in those counterfeit medications either.
Very good. I'm just looking to see if there's any other chat questions. We've had some really good comments. So we'll move along with Kate. Go ahead.
No, Tim, I was just going to mention it in response to your last comment as well. So yeah, tetizolam is available in parts of Scandinavia and other parts of Europe. One of the other early designer benzodiazepines was phenazepam, which was commonly available in Eastern Europe. That kind of seemed to kickstart this market.
And that was a very, very long-acting benzodiazepine, was it not, or is it not?
Yes, it is. Yeah.
So let's move this case. It had some period of time where things seemed better, which actually coincided with the patient's forgetting to send in his driver's license renewal and his license plates. So he's really restricted at home, and his parents are not allowing him to use their car for Uber or other deliveries. And he is engaging in Zoom meetings with his counselor and provider, and then he starts to miss some appointments again. He's brought back for an on-site screen, which you can see this is in June, and it actually was negative for benzodiazepines. Patient reports a month of doing quite well at work, work's going well, is keeping appointments, and then he has a call with myself where his speech is thick and slurred, and we bring him in for another screen, and he denies taking any benzodiazepines. The dip is negative for benzodiazepines. It's sent off for confirmation. And so I'm wondering what other commonly misused substances are taken when someone has a sedative use disorder. What do clinicians see as substitutes for the benzodiazepines that are available? Dr.
Your audio cut out. Who did you request?
Yeah, so I asked. Go ahead. What are you seeing as benzodiazepines?
I typically don't see alcohol substitute a lot, which is what I would think would be more likely. However, I do see, I see some gabapentin. We don't use pregabalin in the Midwest in my area very much. So the other thing that I think is a concern would be things like GHB and phenibut have been coming up a little bit more frequently.
That's great. We had chatting in about gabapentin, and I think gabapentin is the primary substance is substituted. It's not controlled, or it doesn't show up on the PMP or prescription monitoring program in New York. It does in about 20 other states now, but it's still not controlled. Baclofen or phenibut is a supplement common. So some of these other sedative or GABAergic or indirectly GABAergic agents, and the patient's expanded screen that does include gabapentin and pregabalin, and it returned pregabalin positive. And after he was confronted, and he admits he found some old caps from a prescription he'd forgotten about, and his parents were quite concerned because they didn't recall any prescriptions for pregabalin or Lyrica that were in the house. His case in point, though, he seems to be doing better without signs of sedative use and more regular contact with Zoom. This is really challenging with, less on-site interaction. Though we utilize peer counselors, his parents are really struggling balancing support with monitoring, and I think felt that the vaping device was necessary. So, it's a challenging case. Just in summary, synthetic benzodiazepines are increasingly common as counterfeit pressed benzodiazepine tablets. There are a number of different synthetic and designer benzodiazepines available. And there's also difference in terms of the synthetic opioids in terms of scheduling, which make it easier for distributors to order designer benzodiazepines, and the availability is there's much less risk from what I understand. And I'm not expert in, how the benzodiazepines versus fentanyl analogs, for example, would play into the Controlled Substance Act and, the use for human versus non-human consumption. But benzodiazepines, it's easier from what I understand. There are false positive screens that can occur. Sertraline was mentioned. For efavirenz has been another one, but it varies. The cross-reactivity varies by test. And then designer benzodiazepines will trigger the assay positive. Some actually do have metabolites that will then be confirmed, but most do not, and will have a positive preliminary, confirmatory negative, or be missed entirely. And then the gabapentinoids are commonly misused by patients with opioid use disorder, as are some of the other agents. Got a couple of references. One of them was from 2019 and is a good summary on an expanding world of new psychoactive substances focusing on designer benzodiazepines. And you can see this is just part of a chart taken that describes different designer benzodiazepines, what's considered a light and a strong dose and duration of effects. And there's references to corroborate this. And then a paper maybe Dr. Logan can expand on briefly, where they analyzed 97 forensic cases and alprazolam blood concentration that has just come out. And Dr. Logan, maybe you can give us a little bit more information about that publication.
Sure. So these were a mix of death investigation cases and impaired driving cases over the last year or so that we published just a couple months ago. Interesting drug combinations in across all of those different categories. About a third of our fluoprazolam positive cases were also positive for fentanyl. About 10% were positive for buprenorphine. About 9% were positive for morphine, most likely resulting from heroin. So not seeing so many of, frequently with synthetic cannabinoids, you see multiple synthetic cannabinoids in the same individual. With fluoprazolam, it typically wasn't present together with other benzodiazepines. And I'll also just mention one other publication that came out recently in Current Neuropharmacology. The first author's name is Orsolini, Orsolini, called New Designer Benzodiazepines, an Analysis of Literature and Psychonauts Trip Reports. So it gives a lot of great first-hand user information about effects experienced with a variety of these designer benzodiazepines.
That's great. Thank you. And I want to remind the audience that the slides as well as recordings will be available, and we also will have some summary materials provided to the Opiate Response Network, ACMT, and ASAM after each of these presentations, the next, I believe, 5-month sessions at least. Case 2 is titled An Inexpensive, Potent, and Intense Intoxication. Case 2 involves a 44-year-old female who's found acting bizarre by her parents. She has a long history of struggling with substance use, as well as legal issues primarily related to her use. After a period of incarceration, she's been staying with her parents and attending an area treatment program. She's on probation and is check-ins with both probation and with groups counseling and mental health, using cocaine, methamphetamine, cannabis, and a variety of prescription medications, primarily medications to come down from the stimulants. As COVID-19 impacts the on-site treatment, screening, and contact with her parole officer, and her parents notice more erratic behavior, culminating in finding her pacing repeatedly with repetitive movements. She's standing and sitting, getting up and down, rubbing her arms, rocking back and forth. She's had some falls and some injuries and doesn't seem to be bothered by them. She's having these episodes interspersed with staring off in space. They call 911, and she's brought into the emergency department where she's noted to be tachycardic and sweating profusely. And her parents mentioned they think that she'd gotten into something called K2 from ex-boyfriend who intermittently had been caught trying to contact her by knocking on her window or walking by her house. So my questions for the panelists, without really getting into case discussion, we've been seeing much more synthetic cannabinoid availability on the street and more individuals that are using this as just simply a potent, cheap intoxicant. And I'm wondering if any of the panelists have seen the pandemic impact the availability of synthetic cannabinoids. How about in Syracuse, Dr. Hodgman, have you noticed any changes?
I don't think we've seen a dramatic change in those in our area right now. Certainly, we still get the occasional case, but I can't think of anything here like the number of cases we were having perhaps 3, 4, 5 years ago. But we do still occasionally get the the very agitated, delirious person following the use of one of these products.
What about in Minneapolis, Joanne?
It's been similar here. I haven't really gotten a good sense of whether the availability has changed. Certainly we have people come in with unidentified toxic syndromes that could be consistent with synthetic cannabinoids. I'm interested in knowing whether, I think they're doing some research on synthetic cannabinoids for treatment of COVID and whether that would affect it.
Well, that's an interesting question, and I don't have any answer to that, but maybe someone can chat in at comments. Does Dr. Logan, are you seeing any change or increase in synthetic opioids since the pandemic began?
We've actually seen very little change, both in terms of the actual compounds that are currently popular or the positivity. So I know this is one of your other questions here, Tim. And I know it's kind of an alphabet soup of names and they're hard to follow, but the most popular compound right now is 5-fluoro-MDMB-pica. The second most is 4-fluoro-MDMB-binaca. The compounds are different in terms of typically carbon chain length, and then whether they have an indole or indazole core. These modifications in animal models change the potency of the compounds a little bit, but the compounds that are less potent are very short-lived in the market. And there are still new entries, probably every month or so. We'll see a new synthetic cannabinoid, but only a few of them ever really gain traction. Again, as with the designer benzos, a lot of it is people seeking out some new kind of novel drug experience. They want to try different substances. They want to post about it on social media. It's rare that compounds break through and actually enter the drug supply where their use is very widespread. With the benzos, fluoprase, lamivudine are two examples of that. And with the synthetic cannabinoids, the 5-fluor-MDMA pica accounts for more than half of all the synthetic cannabinoid cases we're seeing.
That's very interesting. One of the concerns that I've seen is one of the detoxes I consulted at, the frequency where they're identified during admission has been greatly increased. It seems, with the homeless and along with opiates and a potpourri of other substances, usually opiate stimulants, fentanyl stimulant, occasionally some alcohol, they're being reported. Some of that is, I think, due to being on probation and some use for parole to try and skirt the testing, but others seem to really be, they're inexpensive and available on the street, and still in Rochester seem to be available in some of the bodegas that patients, individuals feel they'll be sold kind of under the counter. So we do see them still at the street level. And I know in Syracuse, where it was referred to as spike instead of spice, where it just had dramatic use of the synthetic cannabinoids, not recently only, but over the past few years, in particular at the homeless and kind of the destitute, is the Thunderbird wine replacement, kind of the cheapest, most potent intoxicant. And maybe, Mike, you can comment a little bit more on, your experience with populations in Syracuse that are using the synthetic cannabinoids or spike.
Yeah, I think when you're referring to some years ago, it was not uncommon for us to see, a number of patients present on any one day, and oftentimes it would be more economically challenged populations, people staying at some of the homeless shelters, and a whole group of individuals might get into one of these products. And, my own opinion was, I think that, when it finally started to settle down a little bit, it wasn't as much, maybe there was less use of it, but people were maybe learning how to dose it a little bit more appropriately. And so as I said, we know it's still around, and it's interesting, just a couple of weeks ago, walking between the Poison Center and the emergency medicine offices, I came across a couple little empty packets that were littering along the roadside. So the stuff is certainly out there, but we really just don't see it as much in the ED. But if I'm looking at this case, and I don't know if you had any more comments on this case, but what I thought was interesting with her presentation was the repetitive movements that you describe and the pacing and everything. And it almost, when I'm reading that, I'm thinking, maybe it's K2, but that sounds dopaminergic to me as well. And I don't know if this was something that also had some sort of amphetamine or methamphetamine added to it as well.
Yeah, that's a great question. This one, there was some other substances that were detected. We did confirm the synthetic cannabinoid, which I don't have as part of the analysis screen. I'm blinking on whether it was one of the more common ones that Dr. Logan had mentioned, but we did confirm that there was a synthetic cannabinoid involved. And I do agree that people are understanding how to dose a little bit more, or whoever is distributing is using less amount in whatever units they're selling at the street level, because I'm not seeing them in the emergency department necessarily as much. This patient did come into the ED, but I am hearing about it by patients entering into detox or inpatients. And maybe Dr. Bishevitz, are you seeing any other trends, or does that mirror your trends in the opiate treatment program or strong recovery in Rochester, or do you have any other thoughts?
I think we see a similar sort of picture. We haven't noticed an extreme uptick in this. And in fact, what I think goes on is most of the time I hear about K2 in retrospect from people because they are very invested in holding it as their secret because they're using it because they know that it won't be picked up in the average tox screen or at the average dipstick thing that the halfway house does. And so later on, though, they'll tell me all about it, and they'll often talk about how dysphoric it made them feel. It's not a very pleasant thing for most people, I don't think.
Yeah, I agree.
Yeah.
Thank you.
Tim, can I just follow up on that too, just for everybody's awareness? We talked about the fact that some of the designer benzos will cross-react on the benzodiazepine immunoassays. The synthetic cannabinoids will not cross-react on the cannabinoid immunoassay. None of them. They're just structurally too different. Even though they're similar enough to activate the receptor, they're not similar enough to bind with the antibody. Again, relying on the history, the person's not going to know exactly what it was they were taking necessarily. You would have to have a more specialized test for that. And then one other observation with respect to patterns of use of synthetic cannabinoids, we were involved in investigation of a couple of incidents last year involving synthetic cannabinoids mixed with fentanyl and some heroin. And these individuals presented in the emergency room as apparent opioid overdoses, classic opioid overdose. They were then given naloxone, which then unmasked the kind of synthetic cannabinoid toxidrome. So they didn't emerge as people typically do from an opioid overdose. They emerged in that more agitated, combative, hallucinative state that you sometimes see with the more potent synthetic cannabinoids.
Thank you. That's very interesting. So the clenbuterol or scopolamine adulterated heroin and reversal with naloxone, you get this surprise agitation and secondary toxidrome. I have not seen that, but thank you for mentioning that. Let's move along to the third case. This is we're switching to talk a little bit about synthetic opioids. This is an extremely restless, diaphoretic, and yawning patient who is 24 and has an extensive history of primarily opioid use disorder, prescribed opioids, transitioned to heroin for about 10 years. And he stopped taking his buprenorphine in May of 2020 after realizing that there was a lot less monitoring associated with COVID-19 in his treatment, and his providers were continuing to call in prescriptions with monthly phone calls. And he said it was just pretty easy to play the game and tell him I was doing okay, that I wasn't taking my subs. And he's just referring to subs generically. Apparently, after becoming tired of the hustle again, he tried to restart his buprenorphine as he'd done previously when he'd been on and off regular heroin, which he said it was very easy to go off for a few days or take lower doses so that he could stop and wait a day or so and then get the regular opioid effect once he resumed heroin. This is not hard to restart from his report, 12 hours after heroin, 24 hours at the most. He waits 48 hours from his last use of what he knows is fentanyl. He knows that the heroin supply in the area is really essentially truly heroin-free, he says, mostly fentanyl. He explains that there was the onset of cramps, he had sweating, malaise, he had a lot of anxiety, he had rhinorrhea and some tearing or eye watering before he took his dose of buprenorphine, and he takes what his normal regularly prescribed dose is as 12/3 milligrams sublingual. And he states that after a period of what he calls restless uncertainty, he describes the feeling that something terrible was occurring and it just kept getting worse. He describes that his legs were restless, his tearing or eye watering dramatically increased, and he couldn't stop moving. He had intense cramps, nausea and vomiting to the point where he couldn't even keep small amounts of water down. So at that point, he calls emergency medical services or 911, and he's brought into the emergency department where his heart rate was 90 to 130 or even at points higher. His blood pressure is elevated, and he's extremely restless. His marked mydriasis, he's yawning repeatedly every couple of seconds, really wide yawns and moving around. He is hearing rhinorrhea. He just can't sit still. Despite this, he was one of the most polite patients I've ever seen with precipitated withdrawal, and he very politely provides all the information that I've relayed, including how he tried to restart the buprenorphine 48 hours after his last use of 2 bags of intranasal fentanyl. He normally used 10 bags of heroin or fentanyl a day, and this had been going on since May. They varied between 5 and 10, but was usually closer to 10 bags a day, depending on his finances. an emesis basin with scant bile next to him, and he's sweating, and he's the tremors, and he has hyperactive bowel sounds and marked piloerection, and he's asking very politely for help. So what is your diagnosis? If it truly was 48 hours after last use of the heroin simply containing fentanyl, why is he having precipitated withdrawal? And then secondary questions are, what types of novel synthetic opioids have you been encountered in the heroin market this past year? And has the COVID-19 pandemic impacted the availability of synthetic designer opioids in the drugs and drug market overall, mostly for Dr. Logan? And then how would you treat this patient? Hey, Dr. Hopper, maybe you can start with what your thoughts are.
Well, this case is certainly prototypic of a lot of cases that we're seeing, and we are limited in our ability to look at what's the exact toxicology. So typically what we'll do in these, it depends a little bit on the clinical situation in terms of inpatient, outpatient, and how well we know the patient. A patient that we have fairly good rapport with, somebody who's very cooperative like this, we're probably going to use a combination of gradually escalating buprenorphine doses along with something from an anxiolytic standpoint, and this might be a time where I might use some diazepam or Librium, and then potentially some clonidine as well. So this is a sporadic case, but we're certainly seeing a lot of cases like this show up every few weeks, and very similar to how this patient describes it. They know that they're getting fentanyl off the street, that they're not actually buying heroin, but they also know that it's mixed with other things, and they have to be cautious about what the effects might be when they're trying buprenorphine as well.
Thank you. You know, I have to say that since the separation of heroin or fentanyl has really replaced heroin, it's dramatically impacted the ability for patients, providers to do inductions. In my experience, you know, my thoughts in the hospital with fentanyl and do inductions 8 hours after the fentanyl is turned off. I have Dr. Schultz, one of our clinical toxicologists, listening. You know, maybe she can chat in, you know, confirming that it's very easy in the hospital setting to start buprenorphine after fentanyl. And what is the difference between the illicit fentanyl and the use compared to how we use in the hospital? And I know it's not just simply all the other novel synthetic opioids. My hypothesis is that there's a defect that the users IV or intranasal are not hitting their intravenously repeatedly with the perfect IV, like in the ICU, so that with repetitive use, you have essentially kinetics in addition to normal intravenous kinetics. So essentially, you're doing an induction into someone that has not only used fentanyl, but has a fentanyl patch that subcutaneous in the nares. They have this absorption, and they don't tolerate the buprenorphine, in particular in high doses, very close to the last use of fentanyl, or they need very, very low, like the micro-inductions we've talked about. So, you know, that's how I explain it to patients, and I haven't heard of any other better really report other than that some of the analogs may be more lipid soluble. I'm wondering, Dr. Bashevitz, what's your experience with this, and you know, do you have any thoughts on, you know, changing into patterns and fear of induction?
Yes, I think not only the patients, but we treatment providers often have a fear of induction because of what might happen if someone is using a lot of fentanyl. And we often end up starting very slowly to observe what happens after, say, 2 milligrams, and just to do a sort of a test dose and to try and make sure that they really have been abstinent from fentanyl or heroin or other novel stuff for the last 48 hours and longer. And I think that there are many scenarios that could cause a picture like this. You know, of course, the person could have taken some kind of novel synthetic opioid, but, you know, there are many other things that could have happened too. Maybe the person had some tramadol at home and thought, well, this is just a weak opioid, or maybe it's not an opioid at all, which many people believe that tramadol is not an opioid at all and could have taken that. Or maybe maybe perhaps the person could have bought something that was sold as Xanax bars, or maybe even marijuana, and that there was fentanyl in there. So maybe the person did not knowingly buy fentanyl. Many scenarios, and you just have to treat them symptomatically, like others were saying.
Yeah, so that's a great thought in that, so you may truly not have waited 48 hours or had another opioid. I have not seen fentanyl adulterated in cats. I mean, I would anticipate we would have horrific, numbers of fatal overdose with the number of cannabis users that are opioid naive or non-tolerant, similar to the cocaine adulteration, higher rates of fentanyl adulteration. But the good points about tramadol. Dr. Lace, do you have any comments about the induction and procedural?
I actually haven't had the same problems inducting people who are using fentanyl or synthetic drugs. Although I have to say, I feel like I've also been seeing less fentanyl around, but even on the intensive care unit, on people who've been on fentanyl infusions, we haven't had a problem when we've started low doses of buprenorphine.
Right, and that's my point. In the hospital, I've not had any problem whatsoever transitioning from fentanyl to buprenorphine. So there's a difference in the way people are using. I think, extravasation, depot effects, and other opioids is, maybe truly less duration in between the time of induction or maybe inadvertent exposure. So, Dr. Logan, can you comment on, any differences in synthetic opioids that you've seen since COVID, or has there been any impact on the heroin market this past year or in the last 6 months?
Sure. So in addition to the toxicology testing we also do seized drug testing for a number of agencies. And the situation currently is that there's very little heroin in heroin. It's mostly fentanyl. And even the heroin that is out there typically has some fentanyl in it also. Our numbers of fentanyl-related deaths have gone through the roof in the first 6 months of COVID. We've seen about a 33%, 35% increase in month over month in the number of fentanyl positives. Currently, we're seeing about 2,500 fentanyl-related deaths each month. In terms of the other opioids that are out on the street, there are still designer compounds that come and go. The major one last year was isotoniazine, little higher potency than fentanyl, but it appeared probably in the late summer of 2019, and as of last month, it was practically gone from the U.S. supply. When it was popular, the numbers of cases were small, maybe up to about 100 in a month, compared to the 2,500 fentanyl cases we would see. But isotoniazine is now gone. The latest substance is a drug called brorphine, which you might think from its name was some brother to morphine, but in fact it's actually more structurally similar to fentanyl. It's not a true fentanyl analog, but it is appearing in street materials being sold as heroin. So brorphine appears to be on the increase currently.
Is that an etorphine analog, or I'm sorry, maybe misheard?
No, so brorphine, in spite of what you might think from its name, it looks nothing like morphine. It's not a morphinan type opioid. It is vaguely reminiscent structurally of fentanyl, but it's different enough that it would not be considered a fentanyl analog even under the core structure scheduling laws. I have some information about it. I'll put a link to that in the chat.
Perfect. I was just going to comment. There's some question spelling, and there's a number of other classes of synthetic opioids that have been available over the last few years. So my last question is really how to treat this patient, and I know that to save time, I just want to go through how we've been able to treat this patient. We gave him some benzodiazepines initially actually was given some lorazepam parenterally because he just still wrestled. Also giving clonidine, and once we precipitated withdrawal or he's precipitated withdrawal, we give back buprenorphine. And I know there's some difference in opinion on how to do this, but my preference is to slowly give back, or fairly quickly give back, small doses one by one. So every hour we gave dose by 0.5 milligram films. By the hour, each with some clump. And at the third dose, he started to feel somewhat better. And once the patient's starting to feel better with that, you can get a bigger dose. And we gave him 8/2 twice. And he's able to keep fluids down, but he didn't really feel like eating until the next day. We continued some of the clonidine, hydroxyzine, and kept him on the higher dose of buprenorphine, 8/2 twice a day. And he commented that that was the literal thing I've ever experienced. I've quit cold turkey before when incarcerated, and it sucks, but it is nowhere near anything like that. I can't imagine it being any worse. We're kind of coming to the end, so I'm not going to go through any other thoughts on treatment of precipitated withdrawal. We've had audience comments about microdosing, and I think that is, increasingly popular, giving very, very small doses of buprenorphine. I would refer the audience to last month's, or 2 weeks ago, with the third Friday webinar. We changed the dates. We just discussed microdosing in the last webinar, and or can email me if anyone has any questions. Comment on use of Bernie's method, which is a microdosing of buprenorphine. Want to end a little bit. The support during COVID-19 patients has both expanded opportunities, but also provides some unique challenges. And I've had a number of patients that I thought were stable and taking buprenorphine, talking to them via phone or webinar or Zoom, and it turns out they haven't been. So I really started incorporating observed doses, utilizing the peer, and there's a lot of, increasing number of resources available on how to support patients with substance use disorder during the time of COVID-19. ASAM has some excellent resources on their website. The ACMT has resources as well. AAAP is the PCSS, the Provider Clinical Support Series. So there's a lot of resources if you're looking for help taking care of patients. I just had an interesting publication from Silverstein on buprenorphine and adulterated heroin, adulterated fentanyl, and the title is aptly named "Everything is Not Quite Right Anymore." And this was, I'm just going to give a quote from one of the subjects they interviewed, and she says she was almost 72 hours into withdrawal, and I took it, meaning the Suboxone, and it made me, I couldn't believe it because I don't puke or get diarrhea. I don't have that happen ever, but immediately, bam, not even 5 minutes after I took it, I was dripping sweat. It felt like I had water had just gotten dumped all over me. I'm puking, and it's coming out every end. And so they had basically a series of questions and interviews and patients regarding the experience with the changing composition of heroin with fentanyl. We are about right at one, or it's over. I'm going to end again with a poem by Raymond Carver, and this one is NyQuil. Carver, famous poet, struggled with alcoholism and with gained sobriety, only to unfortunately die of lung cancer. Describes that in a poem called Gravy. I encourage everyone to read, but this poem is NyQuil. And Carver starts with, "Call it discipline, but for months I never took my first drink before 11 p.m. Not so bad, considering. This was in the beginning phase of things. I knew a man whose drink of choice was Listerine. He was coming down off scotch. He bought Listerine by the case and drank it by the case. The back seat of his car was piled high with dead soldiers, those empty bottles of Listerine gleaming in the scalding back seat. The sight of it sent me home soul-searching. I did that once or twice. Everyone does. Go way down inside and look around. I spent hours there, but didn't meet anyone or didn't see anyone of interest. I came back to the here and now, put on my slippers, fixed myself a nice glass of NyQuil, dragged a chair over the window, where I watched a pale moon struggle to rise over Cupertino, California. I waited through hours of darkness with NyQuil, and then, sweet Jesus, the first silver of light." I want to thank everyone in joining today. We really had a good Q&A and chat discussion, and we will have some transcripts and fact sheets as well as some additional information that are available accompanying the webinar recordings that will be available on the ASAM website, as well as the ACMT website and through the Opioid Response Network. And encourage everyone on October 2nd, where we'll be focusing on cases involving the intersection of addiction toxicology and social injustice, on how chemical restraints and potentially intoxication and incarceration arrest may result in unfortunate circumstances. So I got some good cases for that, and the next dates are in October, November, December, and I want to thank all the panelists for attending, and Dr. Logan is guest expert. He's provided some resources in the chat box, and again, everything is available. This ends the Friday Addiction Toxicology webinar today. Thank you all for attending.